All right, good morning. Welcome to In the Trenches. This morning, I'm going to talk about thrombophilia or hypercoagulable states. Thrombophilia. Okay, we're going to talk about conditions that predispose people to blood clots. First thing to do is review the coagulation cascade. So we have the intrinsic pathway and the extrinsic pathway. Intrinsic pathway, you're going from 12 to 12A, 11 to 11A, 9 to 9A, 10 to 10A, prothrombin to thrombin, and fibrinogen to fibrin, and fibrin to stable fibrin. The extrinsic pathway, you have tissue factor, which converts factor 7 to 7A, and that works down here, okay? And factor 8 activates, it's a cofactor to activate factor 9. This is basically the coagulation pathway, reviewing the coagulation factors. Fibrinogen is factor 1, that's important to know. Prothrombin is factor 2, and activated factor 2 is thrombin. This is the most important factor as far as blood clotting. The other factors, factor 3 is tissue factor, factor 4 is calcium, factor 5 is proaccelerant. There's a debate whether there is a factor 6 or not. Now I think it's considered activated factor 5. Factor 7 is proconvertant. Factor 8 is an hemophilia factor. Factor 9 is Christmas factor. Factor 10 is Stewart factor. Factor 11 is called PTA, plasminogen is called PTA. Factor 12 is Hagman factor. Factor 13 is stable fibrin. Also, these factors interact with calcium and phospholipids in order to work. Now you have to know the players on the opposite team, and the most important factors there are protein C and protein S. And these factors inhibit factor 5 and factor 8. And whether an individual is predisposed to clotting or bleeding, it really depends on the balance of the thrombotic versus the antithrombotic factors, and finding imbalances could predispose an individual to go one way or the other. Okay, the other factor involved is antithrombin 3, which is really called antithrombin, and that antagonizes thrombin. Okay, so these are the players here. Now let's talk about evaluating somebody who has a DVT or a pulmonary embolism. What tests do you order? And this has really changed. So really the first congenital deficiency that was reported in 1968 was antithrombin 3 deficiency. And this is a very unusual, it's not common. This shouldn't be ordered routinely. If somebody's on heparin already, that will lower your antithrombin 3 level, and acute clots will lower it. Then in 1986, they discovered protein C and protein S, and when we were working up patients, we would get levels of these, and these are not that common either. Protein S deficiency, and protein C inhibits factor 5 and factor 8, and protein S is like a cofactor to protein C. It's sort of like the little buddy there. But they were reported, and acute clots could lower them. If someone's on warfarin, these are vitamin K dependent factors along with factors 2, 7, 9, and 10, that could lower them. And really, most of the patients who had clots, we didn't know why they did, the idiopathic clots. It was really in the 1990s when they were able to figure some of this out. So in 1993, Leiden University in the Netherlands, they were doing research, and they found this factor, okay, which caused resistance to activated protein C. It's called factor V Leiden. These patients, about 25% of Caucasian patients who had idiopathic VTE had this. Well, most people who had this did not clot. Also, women who were on oral contraceptives who had blood clots had this. And then 3 years later in France, they discovered a mutation in prothrombin gene 20210A, which these people produced about 30% more prothrombin or factor 2, and these people also had a much higher incidence of blood clots. And interesting, these two were found together more commonly than you would expect via chance. More common in people of Northern European ancestry. This is more common in patients of Southern European ancestry. So these are the two tests that are often positive in patients who have idiopathic VTE. You can't figure out the cause. And when we started ordering them, you found them. You found them in a certain group of patients. The thing with these people, although they predisposed to have first clot, they didn't really predict who would get a second clot. So you have two patients, patient A and patient B, they both have idiopathic DVT. One patient has factor V Leiden, one doesn't. Okay, patient A didn't have a higher incidence of recurrent clot. And these things exist. These are the things that cause it. Now, the secondary blood clots, I want to talk about that in a minute, but the feeling is now people with idiopathic blood clots, most of these patients need to be anticoagulated indefinitely for an extended period of time indefinitely. So there's no real reason to get these thrombophilic tests on most patients, and certainly not antithrombin, protein C and protein S. Now what's interesting, these tests you could get, it doesn't matter whether patients anticoagulate or not, they're genetic testing. Often with factor V Leiden, they initially will get an APC ratio, and if that's abnormal, then they will run the factor V Leiden mutation. Homocysteine is not considered a risk factor. That shouldn't be gotten now. As far as secondary thrombophilia, the things you need to think of, number one, the antiphospholipid antibody syndrome. And there are 3 tests you can get: a lupus anticoagulant screen, antiphospholipid, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1. About half these people have underlying connective tissue diseases, most commonly lupus, half don't. You will see this, and somebody with an idiopathic clot, you probably want to check this, especially if it's a woman who's had recurrent miscarriages. The other thing to think about is malignancy. They could clearly present as a DVT or a PE. This group of patients, it's not recommended you start CAT scanning them from head to toe. They want these patients to make sure, you have to make sure that they have routine cancer screening, mammograms, PSA, colonoscopy, etc. But it should be noted that those tumors aren't the most common associated with DVT and PE. The 2 most common cancers are cancer of the pancreas and stomach cancer, intra-abdominal malignancies, and we don't do routine screening for that. However, blood work's abnormal and something abnormal in physical exam, then you should evaluate for this. this is really thrombophilia. The other thing you could think of is nephrotic syndrome, where they're putting antithrombin in the urine and you have increased synthesis of other clotting factors. Pregnancy is a thrombophilic state. Oral contraceptives, especially third generation, or predispose an individual to blood clots. And more recently, COVID is a very, very thrombophilic state. And these people, you know, if you have a reversible cause, you anticoagulate for 3 months. So the major point in this quick video is factor V Live and prothrombin gene mutation. These are real thrombophilic states that you see. You know, it's really questionable whether you need to order these, because if it doesn't change your management, it may not be necessary. Routinely, you shouldn't order antithrombin, protein C or protein S levels. And with that, I'm going to stop.